Hola colegas, buenas tardes y gracias por la invitación. Me gustaría disculparme por mi español. Este año he aprendido el idioma español e intentarse dar la introducción en español, pero el resto estará en inglés porque mi inglés es mejor que mi español. Jorge me pidió que le explicara cuándo uso qué técnica para reparar lesiones del ligamento cruzado anterior. Primero quiero presentarme. Mi nombre es Juan, tengo 54 años, soy cirujano de rodilla y actualmente soy jefe de nuestro servicio ortopedia desde hace 5 años. He sido jefe del cuerpo médico de un club de fútbol de primera división en Bélgica desde hace 12 años. Yo mismo jugué al fútbol en tercera división durante mis estudios de medicina. So first thing you have to decide when you see a patient is if you go for a conservative or operative treatment. 9 out of the 10 patients we see in Belgium with an ACL tear are patients who play soccer, basketball, who do skiing or motocross. This means they are younger patients who are very active in daily life and in sports and who want to return to the same level, if possible, after this injury. These patients we almost every time operate. When we go for an operative treatment, we normally go for an intra-articular repair using either autologous CMIT and or gracilis tendon or a LARS ligament. These intra-articular repair might be augmented by an extra-articular monoloop or ALL reconstruction depending on the patient. We reviewed our patients a few years ago and we did a retrospective study. In this study we had one group who was operated only intra-articular with, at that time, autologous CMIT and gracilis tendon. And the other group were patients who were operated on intra-articular with autologous CMIT gracilis tendon plus an extra-articular monoloop reconstruction. And we saw that in our service we had a recidive rate of about 9% when we only did an intra-articular repair. And when we augmented it with an extra-articular monoloop reconstruction, we had a recidive rate of about 2%. So from that time on, we always use or do an extra-articular augmentation in case the patients are high demand, in case they do pivoting sports, and in case there is a positive pivot test by clinical examination. Why did I started using LARS ligament? Well, to explain, I have to go back to 2008. At that time, I had one high-level soccer player who was injured in the beginning of the month February. Hola, colegas, buenas tardes. His ACL, and he came to me, and he was bothered because he was at that time end of contract. He was 33 years old, and he wanted to play at high level for another at least 1 or 2 years, if possible. But as he was end of contract, he wanted to have a good operation, that's one thing. Another thing, he wanted to be able to play again by the beginning of the next season. Normally, when I did an operation with autologous grafts, we counted about 7 to 8 months before returning to full sports activity. In former days, sometimes we did the Macintosh procedure, and with the Macintosh procedure, they returned to level at 5 to 6 months, so maybe 1 or 2 months earlier. At that time, there was one colleague in Italy who already used the LARS ligament. I went to see him. I was convinced that it might be a solution for the player. I convinced the player to use it, and he was convinced also. And finally, we did an operation with a LARS ligament, and he returned to full activity at the same level after 4.5 months. He signed a new contract and he played for another 2 years at the high level. When we do an intra-articular procedure, some of my colleagues use transportal approach for the femoral tunnel. I personally go always transtibial, and certainly when we use a LARS ligament, we always go transtibial. Why? Because there is less impingement when you go transtibial. There are less revisions when you go transtibial, as pointed out by a study by Professor Peter Verdonk. When you use a LARS ligament, you need at least 28 millimeters of ingrowth in the femoral tunnel, and sometimes when you go transportal, you don't get this length. I fix it femoral by an endo button or an endo button adjustable, and on the tibia, when I go for a LARS ligament, I fix it with an RCI screw that has either the same diameter of the tibial tunnel or +1, depending on the quality of bone. When it's a very hard bone, I use the same diameter. When it's rather soft bone, I go 1+ to have a better fixation. In the rehab, we go for a full weight bearing as soon as possible, depending on pain, swelling. And this is especially from the extra-articular monolith procedure. We try to get full range of motion in week 3, and we start proprioception exercises and tonifications at week 3. At month 3, we try to go for the more intensive tonifications, plyometric, and normally we try to go from month 4 to 5 to return to sports. These are the goals, but all depends on how the patient was before the operation, how eager he is to go fast, and it depends also if there are other lesions like meniscal sutures or MCL lesions or other ligament injuries. So in conclusion, LARS ligament gives a faster rehab for ADL activities, for return to work, and for return to sports. It has an equal revision rate to autologous hamstring tendons with monolith procedure of about 1.5 or 2%. It gives a better knee joint stability. It gives less post-op complications because there is no need of harvesting the grafts. It gives less operation time, and it gives better functional outcome scores by the patients. At this time, in our service we are performing a TABC study, the time activity based control study, which includes the operation time, the time patients are in the hospital. And this is important for our hospitals, because our hospitals are financed by the government mostly, and the better the TABC study, the more profit for the hospital. Is it a good solution on the long term? We don't know at this moment. As I told before, the first patient I did was in 2008, and he still has his LARS ligament in place. At this time, I only had one patient who needed revision for his LARS ligament, and sometimes it might be more difficult to do revision cases than with autologous tendons, because sometimes it's more difficult to be able to remove the parts of the LARS ligament with the shaver, and you might need some 2 or 3 shaver blades during the operation to be able to remove everything. So I hope this was clear. I'm ready for the Q&A. Don't hesitate to shoot me for the questions, and all of you are always welcome in Belgium to see an operation, or maybe one day I might come to Ecuador if there is an opportunity.
Okay, so I think at this moment we can start the questions. Voy a traducir, si es que se necesita traducir las preguntas de español al inglés, para que el doctor Mievis las pueda responder. En este momento se abre el piso para preguntas. Capaz puedo empezar con una pregunta yo. I can start with one question. Le voy a hacer en español y después la traduciré en inglés. La pregunta es, ¿cuál es su experiencia, doctor Mievis, en el uso de fijación, o cuál es su preferencia en el uso de la fijación con tornillos al momento de usar el ligamento LARS? So the question in English is, what is your preferences when it comes to using screws to fix the ligament, and if you have heard of the use also of reabsorbable screws in this case?
Well, normally, as I told, in the femur, I use an endo button, so not a screw, because the pull-out strength of the endo button is greater than the screws. On the tibia, in the beginning, I used an RCI screw, but sometimes they broke at the point of the RCI or of the bioabsorbable screw, because the LARS ligament is harder than the autologous tendons. And since then, I think since 2 years now, I always use an RCI screw when I use LARS ligament and not a bioabsorbable screw.
Okay.
Also the diameter is important because, as I told before, it depends on the quality of bone. If you have very, very hard bone, it's quite difficult to put 1 millimeter above the tunnel. As I always did with the augulogous tendons, I always put 1 millimeter above. And now when it's hard bone, I put the same diameter, and with soft bone, I put 1 millimeter above. On the tibia, yeah.
Okay, thank you, Dr. Mievis. There's a question from our colleague Fernando Guarda from Venezuela. So Fernando asks, what is the percentage of rejection of LARS? And why do you think is the cause if there is any rejection at all?
At this time, I have no rejections, not at all. And one of the reasons why the reasons why I always use LARS is just when we're talking about finishing grafts. Sometimes you see when you put an autologous graft or an allograft in a knee, then because of some kind of auto-inflammatory reaction, the graft disappears. And that's one of the reasons in revision cases I always use a LARS. So on the LARS itself, I never have revisions or rejections. In former days, and now I'm talking about 15 or 20 years ago, when they started using synthetic ligaments, they had some synovitis and rejection cases, but at this time I don't have them. Even as I told before, in the guy I operated in 2008, he's still living with it and no rejection. In the beginning, I didn't use so many LARS ligaments because in Belgium it was not reimbursed by the government. It was only reimbursed for reasons of revisions or PCL operations. And now since about 2.5 years, it's reimbursed for all cases.
Okay, thank you. Gracias, Dr. Mievis. ¿Hay alguna otra pregunta de parte del público en este momento? Maybe I have a follow-up question. Or if anyone has a question in the chat, we can always see the questions in the chat. But for first-timers, what are your recommendations for surgeons who are going to use the LARS ligament in the first time? What are the tips and tops during the surgery, or how similar it is from the regular surgeries that they have been doing so far with autologous ligament tendons?
It's very similar. Just always go transtibial, as I told before, and not transportal, because transportal you have more impingement, and that's difficult. You can do a notch plasty, but in my cases, when you do a notch plasty, it always come back, and you have more impingement and also more revisions. So first tip is transtibial. Second tip is put an RCI screw and not a bioabsorbable screw. And it's quite similar to the other operations. It goes faster. You win about 10 to 15 minutes. And now, as I told before, my revisions of LARS ligaments are very low. I don't know, is it really because of the LARS ligament? Because I always use, since 12 years now, the monoloop procedure, so an extra-articular augmentation since 12 years now. So we have very low revisions in our cases, and I see a lot of second opinions or third opinions for patients who already have been operated before and have a re-rupture of their ligament because there was no extra-articular augmentation, or because the tunnels were not good, or I don't know, whatever reason. So in that cases, I quite always use a LARS ligament now.
Okay, thank you, Dr. Mievis. There's a question also from our colleague Fernando Guarda. He asks, what is usually the age that you suggest for the use of LARS ligament in your patients?
Well, it depends. It depends on, you can have a guy of 17 or 18 who's fully grown, and you can have one of 17 and 18 who's not fully grown. Normally, they say you have to wait until the growth plates are completed. So, and I normally don't use them under the age of 16 or 17. Normally I wait till 18.
Okay, thank you. I think that could be a question from our colleague Victor Rujano. Maybe not. Could be any Victor or any other user. Se puede hacer la pregunta en español y se puede también traducir al inglés para el doctor Mievis. ¿Alguna pregunta? I see Carol also as part of the audience. Maybe Carol, you have some questions or recommendations to the new doctors that are using the ligament, that are planning to use the ligament? Maybe later.
The main reason why I used it or started using it, as I told before, is because the rehab goes really faster. And because you don't have to wait for a transformation from the tendons into a new ligament. And so it goes really faster. That's one of the points. We are doing now the study, as I told before, and I think I do now about, I think, 75 or 80% of my patients are now with large ligaments. So mainly before there was a reason of reimbursement not to use it. Now I see very few reasons not to use it. So
can you maybe tell us in terms of how fast they come, or in terms of the recovery, how is the rehabilitation procedure compared to your typical autologous ligaments, tendons?
One patient I will always remember. It was a guy. It was a DJ in Belgium. He came to me about 1 year ago, and he had torn his ligament in Val Thorens in France by doing some DJ acts there. But I didn't know him, so he was on my outpatient clinic, and I was asking him what he did for living. And he told me, okay, I'm a DJ. I said, okay, a DJ, where do you play? Well, Tomorrowland and everything. I said, oh, wow, that's a real DJ, yeah? So, yeah. So he said, okay, if you operate me, I want to be back on stage after 1 month. So I operated on him in September, the end of September, and the beginning of November, he was on stage again. So 4 to 5 weeks, okay, it was not a soccer player, but he was always very professional and very demanding on his knee, because when I see him acting, he's jumping on the tables and everything. So it's a real DJ. Yeah.
Yeah, there's a lot of physical activity there.
Yeah, but normally for the soccer players now, well, the main difference in using the autologous tendons now is especially the rehab. You have to talk with your physiotherapist to change the rehab, and you have to explain them why and what they can do. And normally from 4 weeks on post-op, I go very, very fast. It's okay. Also what I normally do is I wait very often 5 to 6 weeks before I operate the patients. So I send them to the physiotherapy before. Only if they are really soccer players at high level, well, they don't want to wait 5 to 6 weeks before operated. So we operate them after 1 week or 2 weeks. But the others, normally I wait 5 to 6 weeks.
Okay, thank you. There's one question from our colleague Fernando from Venezuela, and he asks, we recognize that now about 80% of your patients are receiving the LARS ligament, but what would be the very few reasons why not to use the LARS ligament? In which cases would you rather Not use it.
H.
H.
That's one thing. Or sometimes revision cases where the tunnels are too wide. Because when you have tunnels that are, well, more than 8 or 9 millimeters of widening, if you put there a new ligament of 7.5 or 8 in, there is still some playing on the ligament. And in that cases, when the tunnels are not correct or not or too wide, I sometimes still go for a real Macintosh procedure, as I did before. So only an extra-articular 3-loop procedure. And that's mainly the reasons why I don't use it. So certainly H. And sometimes people want their own ligament because they have been operated before on the other knee with the autologous tendons, and they really want the same surgery. So yeah.
Yeah, and this also, your comment actually is a very nice connection with the follow-up question from Fernando. He says, what do you think about the use of a combination between the autograft and the LARS ligament?
Well, I've never done it before, and I don't see the use of putting an autograft with an synthetic ligament, because you have the fast rehab from the synthetic ligament, but then you have to wait for the autologous tendon for another 6 to 7 months before you let them play. So then you lose the fast rehab. Okay. And also your tendon will be very wide at that moment. And normally the LARS ligament is 7.5. And if you put another autologous tendon with it, you already go to 9 or 10, at least 9, 10 or 11 millimeters, which is most often too wide.
Too wide, yeah. The question would be also, when you use the autologous, the LARS ligament, do you keep the ligament stumps to maybe preserve proprioceptive endings in the stumps?
Well, let's say I leave the main part of the footprint, but I don't leave the rest of the ligament, because 9 of the 10 times we see them, it's completely torn. So there is no much to leave, but the footprint I leave as much as possible.
Okay. Esteban, maybe you have any question or any other questions from the audience? Esteban, any question maybe?
And also, if I may interrupt, a reason why I started using the LARS ligament is normally we have the scrub nurse who prepares the tendon while I'm doing the surgery. And it means I take the autologous tendons, I put them on the table, and she prepares it. But then you are really depending on that nurse. If it's a good nurse, okay. But what we see nowadays is we have fewer and fewer good nurses, and then you're really depending on it, and that you don't have that problem with the LARS ligament. Or an assistant, or the assistants do it, but it's really depending on who is beside you.
That's correct. We've heard from colleagues from Asia that when they are preparing the LARS ligament, they mix a collagen solution with a saline solution and submerge the LARS ligament with collagen. Would you have any comments about this specific preparation step?
Well, one problem in Belgium is that if you want to do that, it's not reimbursed by the government, so that's one thing. So the patient has to pay for it, huh? And most of the patients don't want to pay for that. I don't see the usefulness of putting collagen around it, because you're putting something collagen around something synthetic. So I don't see why they are doing it.
Okay, yeah, it was something that we heard from the colleagues in another country in Asia, and I want to hear your comments about that as well.
We also have some colleagues who put always, even the autologous grafts, in vancomycin solution. I don't use that neither, because the vancomycin is not reimbursed either. And let's be careful, but the infection rate of my ligaments is, I think, 0.1 or 0.2%. It's very, very low, because we operate rather fast. So, and they have just 3 times antibiotics as the knee prostheses have. And I think at this time, about 80 or 85% of my ACLs they are on 1-day clinic.
One-day clinic.
They leave the same day.
Yeah, and full bearing also.
And well, they are allowed for full weight bearing, but most of them use crutches for 1 week.
Okay.
Because it's still painful, because you have to make the tunnels in the tibia and the femur, and that's the most painful part of the operation. But they are allowed for full weight bearing.
Esteban, I think that you open your microphone. Maybe you have any questions?
Yeah, I have a question. You say you dependent on the nurse if you do the autologous ligament, right? So my question is, in time when you use the LARS ligament, you reduce your time surgery?
Yeah, by about 15 minutes. Normally the time it takes to harvest the tendons and to prepare them. So when I normally do an ACL without any other, no meniscal tear, no other ligaments, it's about, when I take the autologous tendons, I always do a monoloop procedure also, it's about 45 minutes. And when I use a large ligament, it goes about 30 or 31, 32 minutes. So it goes a lot faster.
So it's a quite fast procedure as well.
Yeah.
Yeah. Maybe any other questions from the audience? Esteban, I also have a question about the use of, so there's a debate, and also in the field of my research, of creating technologies that can be targeted specifically for active females that may not have, the intercondyle notch is narrower, maybe the tibial slope has a higher angle, or even the muscles and the coordination of these patients may be lower than in the case of the male counterparts. What is the impact that you've seen in your female patients receiving the LARS ligament versus the autologous?
Well, what we're seeing now, first of all, in Belgium, we have a lot more female soccer players than, let's say, about 10 years ago. So really a lot more. And they tear more often their ligaments than men does. So that's one thing. What you sometimes also have in women is that when you harvest the autologous tendons, that they are not so long and not very wide, not very useful. And then you have sometimes a diameter of 6.5 or 7 millimeters, which is not enough. So, and when you go for a large ligament, it's always 7.5. You really can count on that. And you can count on the pull-out strength of what's about 4,200 newtons. So that's a lot more than when you go for the autologous tendons. And we see them, like the man players, we see them in the rehab that they go faster anyway.
Okay, rehab faster, and also coordination and proprioception is
But that's very depending on the physiotherapist. I mean, that's some problem we see sometimes when I normally work with some physiotherapists, but okay, in Belgium they can go wherever they want. And sometimes you don't know where they go, and they come back. Like yesterday or the day before, I saw a volleyball player, a female volleyball player above 18 years. I used a LARS ligament, and now she came 4 months post-op, and her physiotherapist told her to stop the physiotherapy because she was ready. Well, she did a Biodex test, which pointed out that her quadriceps and hamstrings were still about 30% less than on the other side. So I don't know what the physiotherapist has been doing for 4 months, but I didn't let her play because there is too much risk that she has or a re-injury or another injury from an ankle sprain or an hamstring injury or a quadriceps injury. I don't know what, she was not strong enough. So it's very depending on the physiotherapist.
Okay. There's a question.
That's
Yeah,
why
yeah.
also, if you want to use or to start using the LARS ligament, you really have to talk with your physiotherapist. They have to know what you are doing, and they have to know what you want and how far they can go.
Okay. And how would you recommend? Do you recommend a specific physiotherapy exercise regime, or is it something that we have to train the physiotherapist to know how to deal with patients who receive the LARS?
Well, but the LARS, as I pointed out in one of in the video, we already start with the plyometric tonifications after 3 months. So normally we go much slower with the plyometric tonification. So, and we start already really eccentric tonifications after 4 to 6 weeks. So they have to even open chain. So they have to know it.
Okay.
And then sometimes you have to correct it. If someone's come back after 6 to 8 weeks and has some pain on the patellar tendon, okay, you know he or she is going too fast, then you have to slow it down. So there's not one rehab scheme for everyone. It's very individual.
Okay. There's a question by Fernando also in the chat about the use of I don't understand very well the question, but I want to try to, maybe Fernando, if you can expand a little bit more, but it's the use of anterolateral when you use LARS. I don't know what it means, but probably you know, Dr.
Anterolateral ligament, extra articular augmentation.
Mm-hmm.
I always do an extra articular augmentation, always now. Even when I use the autologous tendons, I always use it.
Okay.
Always do it.
Yeah. Specifically in the case of females?
No, always.
Everyone. Okay.
Yeah. When I was assistant, that's okay, already the end of the 90s. so I had 2 professors, well, 2 famous professors, was Johan Bellemans, who was very known, and also Mark Martens, who was also very known. Bellemans was working in University of Leuven, and where I graduated, and Martens was working at in University of Antwerp. And Martens at that time was the most famous doctor on all the soccer players in Belgium, even Italy. Everyone came to him, and already at that time, he did an intra-articular autologous repair with always in the man a Macintosh augmentation and the female a monolith augmentation. And we were wondering, okay, why is he doing this? He told, I don't know why I'm doing it, but it gives very good results. And then, 15 years later, you had the study of Johan Bellemans and Steven Klaas, who pointed out that in most of the cases, you always have an ALL rupture and you need to do some extra-articular augmentation. So, but I already did it from 2012 because our study pointed out that the results were much better.
And there, the question from Fernando is, what do you use for the anterolateral, either LARS or autologous?
No, autologous.
Autologous.
Yeah.
Okay. All right.
Because it's a very small ligament, and LARS is too big for that.
Okay. Any other questions from the audience?
Yes, I have a question. So, LARS have many types of ligaments, the AC60, the AC80, the 100 and 120. So, which of those do you prefer to use and why?
I use the 60 almost every time, the 60, because it's strong enough, it's wide enough, and the the strength of your chain depends on certainly on the screws in the tibia and on the ender button on the femur. So normally it will not be the large ligament who will fail, but the screws on the tibia or the ender button on the femur.
Okay.
And also today
ahead.
I did one special case. It was not an ACL. It was a chronic patellar tendon rupture who was misdiagnosed elsewhere, and I saw it 4 months after the injury. I operated today, and I also used a large ligament, but okay, that's a large ligament for patellar tendon repair, and it's the first time I did it. So sometimes it has to be the first time.
Yes, that is true, and we hope that our colleagues and surgeons who have been connecting to this call can start using the LARS ligament. As far as I know, in Ecuador, Colombia also received the permission from the Ministry of Health recently. I think Mexico is also one of them as well. Venezuela has been a leader, and we have some colleagues from Venezuela here who have, at least as far as we know, in South America, leading the way in the use of LARS ligaments.
So the main reason why I started, or why I still use it, is in the beginning, as I told before, we had about 9% revision rate with only autologous intra-articular. Okay, with the augmentation extra-articular, it went down to about 2% revision cases, which I was very pleased with. But then I wanted to go for a faster rehab, and I was looking for something that could give me and the patient a faster rehab. And I found that at this time in the large ligament.
Okay, there's a question from Fernando as well. What technique do you use for the extra-articular reinforcement?
Most often a monoloop procedure.
The what, sorry?
Monoloop procedure means
Monoloop
you take a part of the vastus of the tractus iliotibialis, and you go behind the LCL and you refix it on the femur above.
Okay, thank you. Is there any other question from the audience or maybe in the chat box? I don't see any questions at the moment. Maybe any comments from Karel, or I think that also Jean-Philippe is connected. Maybe questions or comments from Jean-Philippe as well.
Well, Karel is very often with me when I do the operation, so he can assure that I'm not telling lies.
We believe both. Actually, I don't know if you know the story, but the reason why I met Karel was almost 4 years ago, when I was starting one of my first projects at the Technical University in Eindhoven, and we were using developing different biomaterials for ligament ACL regeneration, and we wanted to use a control with a ligament. In this case, a synthetic ligament was one of the controls. This is a big study, and I was very happy to receive the support from Karel and his knowledge as well. And we did surgeries, and at least at the animal level, you know, the research has to be done at that level. So it was quite a very nice result, very nice paper, and also very nice experience. And that's how we started to discuss the possibility of bringing LARS to Ecuador. And Jean-Philippe here was of very, very big help. I know that Jean-Philippe is telling me that he will meet you, Dr. Mievis, in July 9th. So I think that's going to be a very nice meeting. So I don't know if there's any more questions from the audience, or maybe any final thoughts, maybe to wrap up the conversation.
the final thought for me is that whatever operation whatever you use, either synthetic or autologous, you may never forget to put your tunnels at the right position. That's the beginning of the surgery. Because sometimes our younger assistants, they think, oh, it's very easy when you go for a synthetic ligament, but you have to go to the basics.
Okay.
That's very important.
Don't forget your anatomy, don't forget the basics, and always make sure to spend time with proper location of the tunnels. I see Carol connecting.
Jan, hello. I would like to say something about the use of the AC60 dB, because this is based on 24 years of experience. And as Dr. Mievis said, it's a good ligament, it's a very strong ligament, it has an acceptable diameter. And what is also an advantage, I think, this ligament can be used with screws or with suspension systems. So you don't have the need to have a left and a right pre-orientated ligament. You just have one ligament on the shelf and you can do everything. If you have tunnel widening, you can always use the bigger screw, for instance. Yeah, this was my remark.
Okay, thank you, Karen. We had a little bit of problem listening to you at the beginning, but
you had a problem.
Yeah, there was a little bit of problem. Maybe you can repeat. Maybe you can repeat the comments.
We are in Belgium. We mostly use the ligament AC60 dB. Why? Because this is the ligament you can use with screws. You can use it with the tightrope and the button whatsoever suspension system, and it's not pre-orientated. But my experience is with the pre-orientated, once you pull it into the knee, you're losing your orientation. And anyway, you have to be careful that your fibers are straight and not in one or another direction, only straight. So I think this is an advantage of the AC60 which we are using, is that you can do it. You never have a surprise. You can always use it.
Okay, thank you very much, Carol, for your comment and your clarification. Maybe a final thought would be you already mentioned about never forget the proper placement. Since I think that there are not many questions from the audience, my question to you, Dr. Mievis, would be: would it be possible to share the initial 15-minute video in the chat box so the people can look into that at the free time? Okay.
You can do it, no problem.
So en este momento estoy poniendo la charla del Dr. Mievis, que fue al inicio para quienes no llegaron a tiempo. La charla es de alrededor de 12 minutos 50 sobre las bases del ligamento cruzado anterior y el uso del LARS, así que siéntase en la libertad de usar la charla para su referencia. Nosotros también, esta charla va a estar grabada y después esperamos subirla también a YouTube. Buscaremos la forma y les comunicaremos también cuál es la dirección de la... Pero antes de eso, is it possible to publish this talk, Dr. Mievis, to YouTube? Would it be okay?
Yeah, to me. Yeah, no problem.
Okay, all right. I don't know if there's any other questions from the audience. I think not. So what I can do now is thank you, Dr. Mievis, for your kind time, for your knowledge, and for treating us with a very interesting discussion about the use of the LARS ligaments. And I believe that the surgeons in South America, in Colombia, in Ecuador, in Venezuela as well, and in North America, in this case in Mexico, are also going to benefit from the use. And we're seeing now are more countries in South America who are starting to appreciate the benefits of the LARS ligaments. And this is only positive to see this reaction. We have here says thank you for the talk, for charla, and it says, I think that this user says that he's been using LARS since the year 1996. So from the very early usage of LARS, since the beginning, that Dr. Charbonneau was the creator of such an innovative material and ligament. So again, thank you so much, Esteban. Sebastian, I think, is the operating room. But I would like to thank everyone, Karel. I hope that we see each other at some point. I don't know if you can hear there's an ambulance out. Because I'm very close to one of the hospitals that we work, the Caterina Hospital. But yeah, thank you very much for your time. We will publish these talks for your references. And until next time, thank you so much, and have a really nice day. Thank you all.
Yeah. Bye-bye.
Right. Take care. Bye-bye.
Bye-bye.